takes a minute. So the first presentation is on an update on the recommendations of the EAU guideline. Thank you for the organizing committee to invite us here. It's a real honor. My name is Kamphuis. I'm from Amsterdam. In the next 20 minutes I'm going to show you something on the update in the recommendations in the EAU guideline. My disclosures. So if you read the new guideline, it starts with a new update. So it will take you 3 pages, and then as long as you have been reading the previous guideline, you're done. So for all of you who have been updated, these are the sessions that are interesting, and afterwards maybe you can sit back and relax. For everybody who is not up to date to the fine point, I present the next slides. So on diagnostics and imaging, there's not much new. So with fever or solitary kidney, and when the diagnosis is doubtful, immediate imaging is indicated. And there's no advice on what type it should be, but it says you can do an ultrasound. This is an ultrasound image of a 16-year-old young man. And then, if necessary, it says it's better to do a CT. And this is the same young man, and you see there's quite a lot of stone. Our ultrasound report said multiple stones. I don't know about in your hospital, but that's the kind of things we get. And everybody can clearly see, I think, that with CT scan you get more clear information. If you are doing a treatment of the stone, it's recommended to do a contrast excretory phase. You can do that with CT, you can do that with a retrograde pyelography prior to starting. This is the same young man, other side, retrograde study prior to ureteroscopy. Big question always is if the diagnosis is what is the metabolic part of the stone patient. So there's advice on your evaluation you should do in the urine, in the blood. And you should always do a stone analysis on first-time stone formers, or in patients who repeat stone formation if they have been treated, if they are on therapy, or if it's an early recurrence. So high-risk stone formers, we're not going to go through this whole table, but I think it's important to look at this table once in a while, as, specifically to recognize the patients who you should have for follow-up or evaluate thoroughly, and especially in pregnancy and in pediatrics. It's always important to recognize that there's more to look at than just the stone at that moment. Chances for metabolic problems in pediatrics are much, much higher, and in pregnancy obviously you want to be safe. So the recommendation in pregnancy is to postpone treatment if possible. So in the disease management, not much has changed. We can use non-steroid pain medication, and opioids are second choice. If there's a sepsis with obstructing stone, strong advice to decompress the collecting system with either a double-J or a nephrostomy tube, to take cultures and to start antibiotics. Prior to stone treatment, whether it's ESWL, ureteroscopy, open, percutaneous, it's important to exclude the urinary tract infection and offer perioperative antibiotic prophylaxis in endourological treatment. And in later presentations this morning, we will cover that more thoroughly. On antithrombotic treatment, it says that if a patient is on antithrombotic treatment and therapy cannot be discontinued, ureteroscopy has a preference. And if a stone unit, or if a stone has Houndfield units more than 1,000, ESWL results are lower, so the advice is to do something else. If a patient presents with a Stone Street or Steinstrasse after ESWL or in general, this patient presented with these stones, bilateral, it's advised, if there's a indication for disobstruction, to place a nephrostomy tube and not a double J stent, like we did here. Asymptomatic stones is always a big discussion. So the big question is, can you leave them, or do you have to treat them, and when do you have to treat them? The EU guideline recommends to at least follow them up periodically. Periodically is said to be 6 months up to 12 months. There's no advice on the terms, so how long you should do this, and that's a big question, of course. On uric acid stones, it's important to distinguish those kind of stones and to inform the patient and to try to get them in alkalization of their urine to prevent stones and to treat stones. Then there's some recommendations on shockwave therapy. So you have to do a good coupling, so there's no air involved. You have to keep proper analgesia, so patient stays still and is not moving too much. Control the target stone, so you're giving your shocks at the right place. And if there's bacteriuria, give patient antibiotics, but not standardly. And there are some factors, it's not a recommendation, that make shockwave lithotripsy less likely. So resistant stones in the past or at the moment, if there's a steep infundibular pelvic angle, a long lower pole calyx, a narrow infundibulum, or if it's a big patient with a long skin to stone distance. We always tend to say, although these things might be there, you can shock once, maybe twice, but if 2 times a shock therapy doesn't work, I would strongly advise not to continue that route. Then there are some best practices: no routine double J, low shock frequency, ramping. There's discussion about that, but it might protect the kidney against damage. The correct coupling, image control, pain treatment, no standard antibiotics, and medical expulsion therapy has been showing to increase stone-free rate and lower pain. Then the endourological techniques for stone removal. Recommendation is you should use one, so no real recommendation on which one you should use. This is data from the Kamphuis PCNL database showing worldwide there's quite a variety of modalities that we use to fragment our stones. Then in PCNL, the discussion nowadays is on tubeless versus totally tubeless. I will come back to that in a later presentation. It says in uncomplicated cases, tubeless, meaning no nephrostomy tube, is recommended. There's 2 studies on that with a level 1B grade A recommendation. The big discussion point obviously is, what do we call uncomplicated, and that's up to your decision during or after surgery. And there's some aspects that are recommended not to be tubeless, like the presence of residual stones, bleeding, solitary kidney, extravasation, and so forth. I'm not going into every recommendation that is there, because there's some recommendation on how to position open versus laparoscopic versus endourological procedures in stone cases. And in the end, there's advice on stone size. We're going to take a look at that in a moment. And then it's on what's your expertise, what is possible, and if there's no possibility of doing a endo procedure, you could, of course, do an open or laparoscopic procedure. So here's the famous picture that we always see if we think about the EAU guideline. So we divide the stone in the kidney on lower pole stone and all the other locations stone. Then we say something on the size, and the size is now 10 millimeters, 10 to 20, and more than 20. And then we recommend something. Recommendations can be endourology, so meaning PCNL or URS. It can be shockwave, or it can be rears or URS or PCNL. And you see that you have quite some choices all the time. So there's a first choice, second choice, but you can always make your argument. In the big discussion in this, for me, is that size is saying not so much. So this is always you have a 14 millimeter stone saying the maximal diameter is 14 millimeter, but it depends, of course, if you have an ellipse of 14 millimeter or if you have a circular. So I think in the future we'll be talking about the volume of stones in square millimeters, or how do you say? Not square. I forgot the English word. Kubieke, we say in Dutch. So in ureter stones, it's more or less the same discussion. So we're talking about size. Everybody knows that there might be a difference if it's a long ellipse stone or a perfect circular stone. But depending on the size, you can either go for ureteroscopy or shockwave. And in big proximal stones, there's a debate or whether you not better do a percutaneous approach, take out the stone if it's obstructing, or even laparoscopically. So the medical expulsion therapy, there's a lot of pros and cons. We have the EAU guideline with quite strong advice to do it. For me personally, I don't recommend it, but here I'm giving the recommendations of the EAU guideline, where it is recommended, but the contrapoint is in this big UK study, which is a well-designed randomized trial where it was shown that it didn't work. So I think there's still controversy. If you follow the EAU guideline, if you give medical expulsion therapy, the EAU guideline recommends you to tell your patient there's a debate and that it's off-label use. I don't know how many people do that, because that's a lot of explaining to a patient. Blind basketing is still recommended not to do so, and don't routinely place a double J when doing ESWL. On residual fragments after treatment, of course, when you treat a patient, there's never a residual fragment, but when there are, you should do a metabolic counseling, follow those residual fragments up, consider medical expulsion therapy, and consider treatment. And those things are recommended in the EAU guideline. So on metaphylaxis, I was giving 20 minutes on the recommendations. There's a lot to tell about the metaphylaxis of stones and very limited strong evidence. So in general, I think it's very important the EAU guideline helps you to distinguish low-risk stone formers from high-risk stone formers. I think we all do that, but sometimes it's good to read back what is considered to be a high-risk stone former. And once you have a high-risk stone former, look further than just the stone treatment. Do at least the standard metabolic evaluation and a stone analysis to take out those uric acid stones, those cysteine stones, those hyperoxaluric stones. And these are the basis of the recommendations for patients, is to advise them to drink enough to have a good diuresis volume of more than 2.5 liters. So I ran through it, Bhaskar. Are there any questions?